As dawn breaks over Johannesburg, the busiest city centre in Africa, hums to life as hundreds and thousands of South Africans stream into the city to chase their piece of the golden dream. Thanks to a vibrant revitalization effort over the past couple of years, the Johannesburg CBD is the vital centre of life for the many who study, work and play there. And now, Clinics' First Day Hospital is right in the heart of the CBD to help sustain and enhance that life.
So Clinics has got the longest history in the country of providing the platform for black professionals in particular to be able to deliver care in the private sector. And our oldest hospital in the group, Dr. S.K. Matseke, has been doing this since 1985. And we have got a great experience, and we have got a large network of specialists across our facilities who are highly skilled in different disciplines of medicine. We are really in a very good position to be able to make those skills and expertise available to the communities and the people who work and live in and around the Joburg CBD.
For more than 30 years, the Clinics Group has been striving to identify opportunities and meaningful ways to pay tribute to our founding fathers who epitomized the concept of black excellence from the start. And it is in tribute to these visionaries that this hospital is named after the astute businessman and legal expert, Dr. G.M. Bike.
Dr. Bike was, to me, he was very, very special. From the home front, he was my father's best friend. And there would never be any important occasion happening at home without Dr. Bike being there. So he's always been there. At some stage in my life, I went through difficult times. He was there for me. When I went through my difficult times, he was there to listen for me. When he went through his difficult times, when he had cancer, I was there to be with him. So I've got that special relationship. He's a community leader to me, he's my father to me, he's everything. The founding fathers, like him, is Dr. Bike, but actually he was a lawyer. Okay. Dr. Tato Motlana was a doctor but a businessman. Dr. Mohesi was a doctor, visionary, a businessman as well. In whatever they did, they were quite diverse. Possibly, if you look into his contribution in law, you'll find that it's major. He was the first president of the Black Lawyers Association. If you went into education, you will find that he also features in education. So there was a special breed of people that work across their disciplines.
The Dr. G.M. Bike Day Hospital at 56 Van Villa Street in the heart of Joburg offers healthcare services in dentistry, dermatology, optometry, ophthalmology, physiotherapy, audiology, ear, nose and throat surgery, orthopedics, gynecology, pediatrics, maxillofacial surgery, as well as general elective surgery. The 36 beds in the state-of-the-art wards and private rooms provide a safe and comfortable space for patients to recover from same-day surgeries under expert supervision. The facility also offers Dr. Suite for consultations with GPs and specialists for all who work and live in the city. For the convenience of all its patients, the Dr. G.M. Bike Day Hospital offers safe and secure parking and the use of a courtesy shuttle service for patients who need to be transported between other clinics facilities.
You know, the business of clinics has always been to take care of the previously historically underprivileged people, and we know that our city centers are full of such people. Our city centers are now full of people from outside our borders, from Africa, the north of where we are, and those people have not have had that. They haven't had that the privilege of having the facility like the clinics, the hospital that is coming out now. So this is going to be a fantastic service for all of them. being serviced close to them where they are. I think that's the whole idea of clinics, to serve people closest to where they live.
It is this ethos of excellence that provides a haven of healthcare for the denizens of Africa's busiest city. The Dr. GMBK Day Hospital at 56 Van Villa Street in the heart of Jozi is open to all every day of the week from 7 a.m. to 5 p.m. and welcomes all medical aids. And it serves as a fitting memorial to a remarkable man who dedicated his life to excellence.
The city, originally called the City Clinic, was built in
First,
1985. So as clinics, we decided that
You may continue, Dr. Pila.
Oh, thank you. So there was a video starting. My apologies, colleagues. Load shedding is not doing us any good. I got bombed out because of load shedding. We just started load shedding now. You stopped my video. Zuki, you switched off my video. I don't know what's happening.
Try switching it on again. Sorry, I was switching for someone else.
It's not switching on still. Please enable it. Okay, thank you, colleagues. Sorry about that. A few glitches this evening. As you'd understand, load shedding has caused a lot of problems for most of us. And I just want to welcome you once more to our weekly webinars at Clinics Health Group. Thanks to those who've been joining us every week since we started in 2020. And you are still with us, and we keep still soldiering on with our webinars that we started initially with Health IQ Consulting, but Clinics is now running this webinars on our own. And we just want to thank you for joining us. And tonight we also want to request that, as you can see, that the internet is giving us problems, load shedding, that if you join us, please switch off your video and mute yourself so that at least we improve the strength of transmission for this webinars. And also note that these are CPD accredited webinars. And when you log in, please also make sure that you submit your full details in terms of your information, your also registration number, that we are able to process your registration. Because those who are with the HPCSA will submit your information directly, but those who are with other healthcare regulators, they will then you can submit on your own. But let us know if you're not getting any CPD points or you're struggling with any login details that we when we give you, and also that you, if you're not receiving invitations via email, please let us know and send your information to webinars@clinics.co.za. And so this evening we are continuing with our webinars, and we are excited to have one of our own from our own hospitals, Dr. Victor Malith, who is a general surgeon and currently practicing at Clinics Health Group's September Private Hospital in Dobsonville. And prior to joining the hospital, Dr. Malith was a general surgeon and acting head of a clinical unit at the Petersburg Opolokwane Provincial Hospital in Limpopo. And some of his duties at that time included general surgical procedures such as cholecystectomy, appendectomy, exploratory laparotomy, and thyroidectomy, including laparoscopic procedures. And we are glad to have someone with such skills in our group. Dr. Malith obtained his Bachelor of Medicine and Surgery in 2007 from the University of Juba in Sudan, South Sudan. And from 2011 to 2016, he further completed his MEd at the University of the Witwatersrand and also has a fellowship from the Colleges of Surgeons, CMSA. He's a dedicated general surgeon with a strong record in success in treating and advanced surgical conditions. He's a proactive and high-performing professional committed to achieving the best possible outcomes for patients. And that's what we want to make sure that we have good quality of care. And this evening, Dr. Malith is going to be speaking about the approach to management of a diabetic foot. And he's coming back for the second time, I think. And we are glad to have you again once more, Dr. Malith, and we are eager to listen about how to manage this important condition that is afflicting our people, especially this month. As we said, it's a diabetic month. Thank you very much. Thanks, Ogi. You can share your screen, Doc. Oh, he was bombed out also.
He was out, yeah, but he's joining.
Yes, that's re-entered.
Yes.
Okay, so Dr. Malith, I didn't notice that you also lost connection. We've just done the introduction, so if you could, if you're settled down, you could share your screen. Dr. Malith?
Yes. Good evening, everybody. Sorry for that. In another glitch.
Oh, yeah, we've got glitches tonight.
And there was a problem with the network. It just came back, the electricity, and then I was out and I just came back here.
Okay, that's fine.
Thank you for introduction. I was not even aware, but I just came back while you talked about. I will share my my screen. Okay.
You could share your video for a short while so people see who's talking.
Okay, no problem.
So you do it once, yeah.
No problem, yeah.
And share your screen.
I think we're just going to share it in full. Okay. We just mute that. Okay. Good evening, colleagues. We'll go through today the management of diabetics food. The main problem with this is a very vast topic that if we go through, it's going to take the whole at least 2 or 3 lectures about the diabetic food. But I condense it into a small area that we focus how do we manage from the general surgical point of view, but we'll touch bases also from the multidisciplinary management and so forth. Therefore, basically, from a snapshot of the introduction, Diabetes, as we know, it is in the center of a lot of the complication as we saw. If we look into Olympic signboard, it's the same like what we have. It causes stroke, heart issues, kidneys, and vascular problem, as well as an eye issue. Basically, in terms of the diabetic foot alone, as we come out as a vascular or neuropathic issues, it account about 70% of lower limb amputations, and foot ulceration and sepsis and amputations are the feared complications that come from the diabetes point of view. Okay, what is a diabetic foot? Basically, it is any infection that involving the foot in a person with a diabetes, which is originating in a chronic or in acute pattern, which is involving the soft tissues of the foot with even evidence of a pre-existing neuropathy, either neuropathy alone or neuropathy with ischemia or only ischemia alone. Okay, and that would lead us from our talking point, it lead us to classify how can we classify the diabetic foot, and also as well as how we stage it. Why do we need to classify it? Basically, we need to know, we need to have a standard way in order to, which is useful in order to assess the etiology of diabetic foot, to find the prognosis, or define it, or facilitate the appropriate treatment, monitor progress of the treatment, as well as serve as a form of communication among the clinicians, and as well as among ourselves. How do we communicate when we say this is great and so on and so forth. Basically, we don't have a universally accepted classification of diabetic foot, but we have got a few of them decided in order to condense it into a few what we will talk about them now. Classification of diabetic foot is based on the etiology, and that's etiology basically, where does it come from, the diabetic foot. Here we're talking about, sorry, I'm just going to stop a little bit because my battery is low. Yeah, it's better now. Okay. Yes, better. Okay, it's based on the etiology. Basically, neuropathic foot, because the dominant cause of this foot issues is due to neuropathy, and that can be subdivided either because it, with infection we go A, or without infection is B, or neuroischemic where there is ischemia is a dominant, and then as well will be subdivided in A or B. Okay, basically I selected from the pool of classification that we have for the diabetic foot. One is according to natural history, which is being described by Edmund and Foster, into the stage and clinical finding. Stage, we have in stage 1 until 6, and based on that, what is the finding clinically when we say stage 1? Stage 1 normally is a normal foot. Stage 2 is a high risk foot, and we will come and talk about what is a high risk versus a low risk. And then 2 and 3, which is ulcerative, there's got ulcer, and 4 when there is a cellulitis, 5 when there's necrosis or necrotic tissues, and then the 6 in which the patient is at risk of major amputation. In terms of TMA, which is transmetatarsal versus to below knee amputations. Second classification that is mostly widely used, which is Wagner's classification of diabetic foot, which basically has got the same level, but in this with regression from 0 to 5. And as it is displayed, 0 is is equal to intact skin. Stage 1 is superficial ulceration. Stage 2, when there is a deep ulceration going down to the tendon, bone, or ligaments. And stage 3 is when there's osteomyelitis and even on the x-rays. And 4 and 5 is gangrene, but gangrene depends, is it extensive or minimal? Minimal is 4 and extensive is 5. Okay, this is the Wagner's, which we selected is the most widely accepted, been used a lot. If you look into grade 0, which is no ulceration in high risk, basically these are high risk patient, which a patient with a neuropathy, a patient with callus formation, with some deformity is a high risk patient. In the superficial part of it, you can see a grade 1, we have got a superficial ulcer, which is not going deeply. Grade 2, we have got the deep ulcer, which goes down to the tendons. And grade 3, you can see is deep with the cellulitis, 4 with the gangrene, and to the toes, whereas the extensive one goes down to metatarsal until down to the heel. Basically. Now, what is the pathogenesis? How does we get the diabetic food in terms of patient with the diabetes, as we said earlier? Basically, it is multifactorial and it's quite cumbersome and complex sign and pathogenesis, pathophysiology, what happened at the level in order to give us into diabetic food. Basically, when we have got the most dominant is neuropathy or vasculopathy, where we mean, in other words, ischemia, or the third main cause is immune dysfunction, where there is all the aspects of immunity are low, although you have got all the cells available, but they cannot carry out their function as from the immune aspect point of view. Then the main cause or denominator all this is because of prolonged hyperglycemic hyperglycemia level, which contribute to whatever we're seeing from the diabetes food. Okay, what does we know about a neuropathy? Because this one is when we expand or what we're seeing here as a 3-point, it's a lot to learn about. The neuropathy is subdivided into a sensory or motor or autonomic. Sensory, what this does imply, basically when we have got a sensory loss, it comes in form of glove and stocking, basically. And what does it imply? The patient cannot feel their feet or any sensation, pain, and positional as well at the same time. And that lead from the sensory loss, it lead a patient to get into the injuries. And then those injuries will lead later on into sepsis and so on and so forth, and then lead to diabetic septicemia. That's where from the sensory aspect of it. Also from proprioception point of view, also, a patient cannot sense the joint positioning. It can walk and then it can twist his leg and so forth, and it can cause injuries at the same point of view. From this, from the somatic aspect, which we call that motor function, is also because you lose the position, you lose, and basically you can twist and broke, or when you twist your leg or the joint, and then you could lead to deformities, and also sepsis can happen from that point of view. Or later on, it goes to what we call Charcot joint. Autonomic is basically we lost autonomic nervous system. And the key aspect on this is a patient lose a sweating aspect, and then the skin become dry. When the skin is dry, it leads to fissuring or cracks in the food, and then later on, those cracks in acquired microbial aspect of it go through those cracks and cause sepsis and then lead into diabetic foot. Therefore, in all those neuropathy, therefore, there is a lot to, okay, from the neuropathy point of view, because if it is neuropathic food, therefore they will develop into deformities, callus formation because of abnormal gait, because of what we say from the motor point of view, from the sensory point of view, you lost sensation and lead into injuries, and as well as autonomic aspect when you cannot feel, when you cannot has sweating and so forth, and then a moisturing of the skin, and skin get dried and cracked and so on. So, okay, vasculopathy, which speaking aspect is a ischemia, whereas the dominant aspect from this ischemia is because we have got a neuroischemia. The other word we say, there is an aspect of neuropathy, but the dominant aspect from this one is ischemia. And the ischemia, as we know from the diabetes, we subdivide into either microangiopathy or macroangiopathy. Macroangiopathy, we know it is involving the large vessels, and that's atherosclerosis, and that's decrease the diminution of the blood supply and so forth, and giving us macrovascular disease. Whereas in microangiopathy is basically a small vessel, especially going to the peripheries, which become basically solidified, and they cannot allow fusion and so, and then there will be ischemia at the level of the arterioles, and that can lead into ischemia and digit loss, and leading to either minor tissue loss or major tissue loss, leading to amputations. Okay, the third aspect of this pathophysiology of diabetic foot is immune dysfunction, and that is basically all the immunes in the immune system. We depend on the polymorphs, which is polymorph neutrophil, which is PMN, which is we depend on those white cells, where from the aspect of function, they need to migrate into where there is sepsis. They need to phagocyte the microbe. They need to discharge their material, especially hydrogen peroxide or free radical, as we say, in order to kill the bacteria, and as well as chemotaxis. Those aspects are all decreased or impaired when there is a prolonged hyperglycemia, which is in diabetes. Okay, basically, if we reflect from that aspect, from the pathophysiology, how do they come to us? Basically, diabetic foot should have to be managed in a sort of multidisciplinary team, including the first person is glycemic control, which you need a physician, and then also to prevent the food, we need a podiatrist, we need a surgeon, we need a dietitian, and so forth and so forth. Therefore, we need to be managed in a multidisciplinary team. Yeah, in this aspect, how does the diabetic foot come to you? Basically, it comes in form of either it's a neuropathic or neuroischemic food. And this, what is a neuropathic food? When they come to you, they come with, they don't have sensation. Clinically, the food is warm. They've got bounding pulses. They've got ulcers, which can be at the pressure point, basically, at where we have got head of metatarsals, at the heels, at the basically the tip of the toes inside, and that where we find the ulcers in neuropathic foot. They can come also with the secondary sepsis, because they've got injuries, and then now they get sepsis. They've got callus, which now develop sepsis within deep into that callus and ulcerate. They can form abscesses, or lastly, they can lead into gangrene formation with a gangrene, which can be either minimal or extensive. Neuroischemic food, how do they come? Basically, they come as a pulseless, because the food there is ischemia, you will not get the pulses, especially at the dorsalis pedis and posterior tibialis artery. They come with cold absence of calluses, which is differentiated it from basically from how do you call it? It differentiated from neuropathic food. Then they come with the necrosis, especially at the margins or the tips of the toes, and that telling us this is arterial disease. Arterial disease always is at the lateral aspect of the foot, or is basically mainly to the lateral aspect of the foot and to the toes. Okay, maybe they will come with features of a critical limb ischemia. What it means that critical limb ischemia the foot is painful, pulseless, and cold. Okay, these are where we came from the clinical aspect point of view. We took out the characteristic that we differentiate what is the neuropathic versus the neuroischemic food. We have got a temperature, pain, skin color, callus formation, ulceration, peripheral pulses, ABIs, mean ankle brachial index, which we do it with the ultrasound, basically with the Doppler, and then also with the complication if they have got Charcot or not. Okay, critical. Basically, in neuropathic, the foot is warm. They don't have a problem with the blood supply. It's basically nerves. Therefore, they will have got a warm foot. Whereas from the other aspect is the foot are cold. Pain is painless in neuropathic because they lost nervation, whereas on the other aspect is painful and so forth. The most important aspect from this is differentiates the callus formation. When you have got a callus, that's basically is neuropathic. And from the other aspect, there's no callus formation. Complication, neuropathic food always, they get what we call Charcot joint, which is one of the orthopedics emergencies. It need to be identified earlier based because it doesn't different from when you have got other complication, diabetic septic foot. But the management is different from the diabetic septic foot, gangrene, and so forth. On the neuroischemic, they will get a critical limb ischemia, which basically we need to warrant revascularization of the feet. Okay. How do we manage it? Basically, as I said earlier on, the management is based on multidisciplinary form. If it comes with a complication already, we go into 5 aspects of management. One of the 5 aspects of management is mechanical control. Okay. It's a mechanical control. 2, metabolic control. 3rd one is microbial control and vascular management, as well as patient education. Okay. Still, we're going to differentiate all along the way. Is it neuropathic foot or neuroischemic foot? If it is neuropathic foot, basically we aim for ulcer management, is acutely management or subacute management. In early, when they come to you with ulcer, we clean the callus. Callus, you need to have to remove the callus with the scalpel. Infection eradication, you can eradicate with antibiotics and reduction of the weight bearing by bed rest. That's the first part. 2, you need to, or the other aspect, you need to exclude the osteomyelitis to do X-ray of the feet. Send some parts of tissue to be cultured. If it is basically, now you need to define if the sepsis is superficial or deep. If it's superficial, you can treat it as an outpatient with antibiotics. If it is, and the simple non-adherent dressing should have to be applied. If it is deep ulceration, you should have to offload them, and that offloading we do what we call total contact plaster cast, which is in order to offload the foot from pressure, should not be to have put it on pressure. For the ischemic aspect, this ischemic food you need to go through the vascular route in order to investigate, first of all, before you embark on management. The first thing to do is it requires vascular investigation. We do the Doppler to assess the ABI, and we spoke about ABI earlier on has its ankle brachial index, and we will explain what it is mean. Basically, when you have got, is subdivided into 4 aspects. Normal ABI is equal to 1 or is around 1. If it is more than 1, that means that vessels are the atherosclerosis they are hardened and they are atherosclerosed. Whereas anything between 6 to 9, anything that is less than 9, telling us there is ischemia. Anything between 6 to 9 is telling us a grade 1, and anything less than between 3 to 6 is a significant decrease ABI, and that telling us it's going to critical ischemia. Basically, you do a Doppler in order to check for ABI, check also for duplex scans, MRI. MRI, basically, we opted in to use them, especially in order to diagnose if they've got atherosclerosis, if there is any blockage at the level of any level on the vessels. Or you can do a conventional angiogram in order to check where is the blockage. If we notice now there is a blockage certain area, you can do angioplasty, which is also as a sort of investigation as well as intervention at the same time. And you can plan for distal bypass in order to salvage the limb. Yeah. Especially now, if there is ischemia already and there is a gangrene, basically when we have got ischemia, it will go later on into dry gangrene. And then if you have got a dry gangrene already at the level of the foot, you have to do foot amputation. If the foot is not revascularizable, or you leave it to auto-amputate, which most of the time we do. When it's a dry gangrene without sepsis, we leave it to auto-amputate. It is extensive necrosis, we go to for BKA, is below knee amputation. Okay. If in the neuroischemic foot, if you have got a rest pain, this rest pain is indicate that the patient is going into critical ischemia and need revascularization, which in order to relieve the rest pain. If it doesn't help, we can go for palliative for pain with a lumbar block analgesia, and at the last resort, you can go for BKA. Yeah. For those who are, we spoke about the subacute and there's an agent stuff. Basically, what are the agent, the sign that or danger sign that you require a patient to be immediately attend to. One of them is the redness and swelling. Okay. If they develop cellulitis, discoloration, and crepitation is telling us it has got a gas gangrene. These are the danger signs that you should not miss. If the foot is pink, painful, pulseless, and even without gangrene, that tell us that this patient has got critical ischemia and warrant revascularization for the neuroischemic. Okay. The agent treatment that you can apply for this patient or emergency setting, they need a bed rest They need IV antibiotics, which is broad spectrum and in combination. We need basically the microbial that's involved in this sepsis is a polymicrobial, and that warrant broad spectrum as well as combination of treatment in certain aspects. Basically, you need a glycemic control where you need to do intravenous insulin pump. You need a surgical debridement if it is warranted with debridement, or you need to incision and drainage, or debride the devitalized tissue, or you go further for either it is to take out the toes or take out the forefoot, which is not appearing as a transmetatarsal, or you go for above knee amputation. If this at the end of the end of your treatment, it becomes successful, there's no need for further amputation, you can do split skin graft after granulation. Okay. Long-term management, because we divided now this acutely, which is urgent, subacute, and then long-term management is in order to footwear. I'm sorry for the glitches for writing as not for wear. It's a footwear. You need to look at what the wear that they use. You need to have a soft one with a broad end, should not be a tight, and should not be the one that you can have tight and cause pressure point. The footwear should have to be designed as for diabetic foot. And that requires podiatrists and routine follow-up and screening for sepsis in between the toes, calluses, if they're developing, they need to be shaved off, and so forth and so forth. And routine examination of the foot. Two, you need to have a screening and prevention. That's, as we said, routine examination, sensory tests, pulses checking, and for footwear devices. I'm sorry for this mistype. Then, if they develop any deformities, like a foot deformity is one of the deformities is chakra joint, or if there's got the valgus, rigidities, and so forth, the hallux and the hallux virus and so forth, of those deformities that come to the foot, then all colors of skin deformation, you need to be detected early, and then they need to be corrected in terms of to prescribe what they need to be done. Especially if you've got colors, they need to be shaped. If you've got deformities, they need to be repaired for orthopedics and to be advised for proper footwear that can correct them. Okay. Now, basically the prevention, which we should have to learn initially, but because we're coming with the diabetic foot, and we are the last resort, we are aiming to start with the measures and then end up with prevention. Okay, prevention the guideline we spoke earlier on, what are the low risk, moderate risk, and high risk food. Basically, is when you look into the food, the patient with a low risk, what does it mean when you have low risk? You don't have the patient with a sensation and pulses. This is from basically neuropathic or neuroischemic foot. If the patient do have the pulse, does have sensation, doesn't need much in it, from the prevention point of view. What it needs is a foot care education. They need to be educated what it does need to do. One of them is in order to regularly check in the feet, should not go barefooted because of the risk of injuries, and should have to look in between the toes, or whenever you come to podiatrists, should have to be seen through from the toes and so forth. Therefore, need to be educated in order to look after his foot. If it is a moderate risk food, basically in this, the patient has got neuropathy. He doesn't have sensation, he doesn't have pulses. But in this aspect, you need regular follow-up with a podiatrist, regular as with his focal point of treatment, with the GPs, with whoever is looking after him, in order to have a regular, every 6 months follow-up, and then to be educated what you do with this food. If it is a high-risk food, which is now is ischemic, it's got deformities, it's got skin changes, a shiny skin, loss of hair, or even with ulceration, you need it every 3 months follow-up, and then you need to intensify your food care education. And as over all of this, the denominator of it is the glycemic control. They need to control the glucose level. Okay, thank you. Thank you. Back to you, Dr. Bila.
Thanks a lot, Dr. Malith. No, thank you for the presentation. And it's quite interesting to cover this quite an important topic that I think it's still quite common to be seen in the wards. And I'm sure colleagues have seen that also, patients that they refer to you. How common have you, I mean, how often do you see these cases referred to you in practice?
Yeah, please. Am I still? Yeah, I'm audible. Yeah, look.
Yeah, you still, yeah.
Diabetic foot is common, and it's a common. We see it a lot, but from the private practice point of view, we don't see them a lot. We see a few which come in. I've been with, I think, 3 cases which are not okay that we manage, especially when I'm in this practice. I manage 3 of them, which they came late. One we have got is a neuropathic foot with a sepsis and is not looking good. And it's still not even amputated now because he's declining and he's in sepsis and keep in and out. It's not looking great. Therefore, basically, it's common. In terms of other aspect of our care, which is in government, we see them every day, and it's quite common. And it is a judgment to our primary health, basically, because that's where it is detection of what is happening from the food point of view, called glycemic control, and so forth. And it's basically also not that's our primary health care. Basically, it's because of socioeconomic status as well, because which doesn't help with the control of our glycemic level, and then hence it leads into complications. Therefore, it's common, and it's all about what happened from the management of the diabetes point of view. Hence, if it's not well controlled, it goes into the level that it gives us complication, and complication leads into amputation. Therefore, it's common. If we don't see it much in a private practice setting, because of the accessibility, but it's there.
Is it? Okay, could you say perhaps it's more about patient education? Perhaps some of the patients that we're seeing in private practice have got access to nursing education about food care when they're diabetic. Okay, basically in terms of the food care, yes. Basically is the most important aspect, because the main problem, the most complication that we get is neuropathy. And that food care, basically you need to look into in terms of what do they wear and what they should have wear,
Okay. And what do they understand? The first of all is the understanding of it. And if they do understand what the type of where they should, okay, and they need to keep checking self-examination of the food every day to see in between or clean the food properly. If they see there is any change.
Yeah.
And that's the most vital aspect. And especially the most important that sepsis that happen is the fungal sepsis in between the toes, in between the webs and so forth. And to not wear the tight foot wear, which can cause pressure necrosis and pressure point, so forth. These are the main thing that you need to be looked into, especially in at the level of podiatrists, because that's where they need to be helping a lot at the podiatrist level.
Yeah, no, thank you very
If
much.
they've got deformities, if their toes are too long, they need to be shaved in certain way, not to cause ingrows nail, and then that later on will lead into sepsis point of view.
Yeah.
Yes. Yeah.
Okay, thank you very much. Malith van der Bogait was quite skeptical. He says that when you go through the list of tests or investigations, she says these are quite expensive. It's an expensive array of tests. And comment on that, and also which of these will give the best information. If you have to, do you have a choice as to which ones you do, or you have to do the whole array, or you know, and which one will give you the best information in terms of how to manage these patients?
Yeah, I think it's a good question. It's not all for, I can suspect it, that one is it for the neuroischemic food. That's where the question came from okay, I think that's where it possibly coming from. But the best thing that you need to do from the beginning is a Doppler scan, the Doppler and duplex, which are very simple, they easily interpretable, and then they give us what we need to know. Okay, but if those things are not giving us what we need, we go further, and that what we do is a peripheral angiography. That what we do, which we can, it readily available has a CT angio, and that can give us the answers, not to go for MRI and the others. And red cell scan. Red cell scan, we do it for deformities, especially for Charcot joint and all those. That are quite expensive, cumbersome, and they need a vascular surgeon in order for interpretation and so on. When I went down to angioplasty, is a procedure basically, which is investigative procedure, need to be done by vascular surgeon and so forth. So, therefore, what we need is a Doppler, and to get the ABI, and then a duplex scan, which is also in that point of view. But if it doesn't telling us much, then we go for CT angio preference.
Okay.
That's yeah.
Yeah. Someone commented about you spoken about the podiatrists that they have a role in management of diabetics. When do you actually refer to a podiatrist? Okay.
Basically, when you find already those patients, they have got at the level of where we classified them already, coming into either the low risk, moderate risk, or high risk. These are the patients that you need to be followed up closely. When they have got the patient already, we knew it has a diabetes. There is a role for podiatrists already. But when the level reach from the low risk to moderate risk, these are the patients they need to go. They don't have sensation, the pulses are going off. These are the patients that they need to go to podiatrists to start assessing their feet, check for any pressure point, if there is any callus formation in those, and check in between, and toe as well. They need to be the one who managing their toes, because if it's been cut by themselves alone, it goes into ingrown toenails, and it starts the sepsis from that point of
Yeah.
view. Yeah.
Yeah, and Philip Lebesi wants to know, is there any role for antimicrobials, microbial creams in diabetic food, managing diabetic food?
Yes. Topically, topical antibiotic, it doesn't have much from it. What you need to do, if it is sepsis, evidence of sepsis, you need to give systemic, basically either oral or IV antibiotics. Topical, it basically it has got its own role when you have to prevent. When you see there are little, especially when there are, how do you put it? When the patient has got any colonization of the feet and they come and ask you, look, I've got bad smell on my feet, and that's where you need to go for treatment of that, because we know what's happened with those feet is fungal sepsis, fungal colonization, and you need to treat them. That from the sepsis point of view, when it is been to eradicate it, or oral, and then we need basically our cream that we use in order to treat the local sepsis, whether you use Malith, but Malith, we know it increases sugar level. You can use anything that can deprive. But the cream point of view, in order to
Okay.
think it's not much addition from it.
Okay, thanks. I keep on losing you. I'm not sure it's my reception or yours.
Possibly mine.
Yeah, if you've got a leg ulcer, septic, and the need for surgical debridement, and also maybe if you could comment about also when you've gone in and did that debridement and you follow up the patient and you've got to, I'm not sure if you spoke about the wound careness, the involvement there, and how often should they come back after being seen or if they are under the care for wound careness?
Yeah, I think that's another part of this multidisciplinary. We need wound care. But yes, basically, as we said, from the extensiveness of the wound and the complication that they come from it, either there is a necrosis which is extensive, basically need amputations, debridement if it is callus with a minimal sepsis, you go and take out that callus and debride minimally. And if it is involving the toe, which is it already been necrotic, we take out the toes, which we saw either toectomies or reamputations. If the whole forefoot is involved, we take out the forefoot has a transmetatarsal amputations. And if it is involving until the heel or the underneath of the heel, that patient it will need some sort of major amputation, which is a below knee amputation. And that's from that point of view, if it is extensive, we don't close it, we leave it open and then continue with the dressing with the help of wound care to help with the dressing. And then after eradication of the sepsis, then we can plan for closure. And that's what I put it at the end and on. After this, the successful treatment, local treatment with the wound dressing and eradication of sepsis, if it's granulating, you need to do a split skin graft to close it, or you can do a formal below knee amputation. The other aspect of multidisciplinary team is a wound care in order to help with the dressing. If they cannot be debrided at the same time, they can use a de-sloughing agent that they can help with that, even including using the vacuum assist dressing.
Yeah.
Thank you.
Thank you very much. Yeah, so there's also comments about glycemic control that is very critical, and we've spoken about the podiatrists, as you said, multidisciplinary, but it begins with those patients who are diabetic. There should be proper glycemic control and food care thing. Someone commented right at the bottom there, said that every diabetic patient must be referred to a podiatrist. Would you concur?
Yeah, as I said earlier on, if you have got a diabetes, they'll at the point they will get into those complications, especially neuropathy, and that's and because of the glycemic control, which basically we have issues with it from our socioeconomic point of view, then they should have to go for food dietaries in order to prevent the infection. Basically, it's not because in order to when it's already been happened, but in order to prevent, even as simple as how to manage the food in order to take out the toes and cut the nails and look in between the toes, and so to teach them how they can after their food.
Yeah.
I can concur.
And Thomas Shaw says, okay, sorry, I keep on losing you. In low literacy communities, would you equate the prevalence of diabetes mellitus and diabetic food that they, is that a correlation in low literacy communities?
Basically, I don't have any data to say from that, but the problem with this is basically you with that you will be having a problem in glycemic control, because you need to have a certain aspect of diet, strict diet in order to follow. And then if you don't, then you will get into complication at the end of the day. And we're seeing it from our small thing when we have, but I don't have any data that to support my assertion. Yeah. Therefore, there is from the when we can, which we see because of what, if it is there and somebody is not looking after the glycemic control, then you will get a complication definitely. Therefore, there is a correlation, but I think that's the area that we need to go out and get data from the research point of view.
Yeah, there's one of the very painful comments here, concerning comments from one of the Ashraf. Says we see a lot of diabetic food escapees from hospitals expecting help from us in the primary care, and it is really difficult to encourage them to return to hospital, and they usually end up going to alternative practitioners like herbalists or even perhaps cultural care. I suppose means.
Can you repeat that? I was reading here.
Sorry?
No, I'm saying it only 100 registered podiatrists in okay. I'm just looking down. What is the comment said?
No, this one is, you want to see it's sent to me directly. The comment is that in primary care, some of the colleagues here are saying that they are seeing quite a number of patients with diabetic foot who I think some RHT, they leave the hospital and they go back to see them, and it is usually difficult to encourage them to go back to hospital. And instead of doing that, they end up seeing other practitioners. They will see traditional healers or see herbalists. How do we encourage them to stay in the hospital?
Sure, and thank you for that. It's a good question, and that's what I say. One of the 3 patients that we've been with him, it's quite a difficult understanding. And you see from our knowledge from the community that we have, whenever you have got a small, what they have from outside, when they come to hospital, a small, a small wound in the feet, and then it was amputated. That's whenever a patient comes to the hospital, they have got that notion in their mind. Okay. If it comes to us to come and manage in the hospital, it's difficult in order to mitigate without warning somebody that's where it's going, you might be losing it. Okay. And that's the most distressing aspect of it, which we always in social worker, psychologists to be involved in order to speak to the patient and then is to educate or to give them aspect of what is going. Therefore, it's a difficult aspect. The patient always need to, whenever you speak to them, it is extensive necrosis. You cannot do away with just debridement and leave the bone exposed and so on. So it's quite a challenge in order to make them understand where is the level that is happening and where we're going. Therefore, they end up signing RHT because most of it is not acceptable from what we, as I put in the background earlier on, they're understanding all the patient coming from outside to come hospital and the families, they understand what a small wound and it need the foot to be amputated or they take out the toe. And it's quite very distressful to lose part of your body. And that's where you see most of them, they RHD because they don't agree with the management proposal. That's the problem. Therefore, in order to encourage them to stay, it needs a lot of aspect to be involved, especially social working. We don't have them in private aspect. Most I don't see them, but we have got some. And we have got a social psychologists, which need to play a lot of role in this. And basically that's what we need. But in order to keep them in the hospital with the sepsis that is going to go up and up and up, you might be ending up later on with a disarticulation of the foot or buff knee amputation. I think it basically is pointless, and that's most of them. They opted in order to go out, and basically they're going to sit there and then come back later on with most at the ages of their life with the extensive sepsis, septic shock, and so on, which is painful, but I don't think what we can go around apart from the arrangement where we have psychologists that mitigate, explain, and so on. So yeah.
There's a question from Dr. Mashiro, one of our regular participants. He wants to know, is Charcot a bad prognostic criteria? I'll come back to the one about podiatry, because it looks like there are a lot of colleagues who are here on podiatry today. Charcot foot, is that a bad prognostic criteria?
I just want to explain with it and then coming. The Charcot joint basically is a deformity joint. It comes from the neuropathy. Basically, you don't feel, you don't sense where is your foot, and then you twist and basically involve mostly at the ankle joint. It lead into later on in illicit inflammation reaction, and then the joint gets swollen and so on. So, to differentiate it from the septic feet that have got necrosis and so is most important because they need to be managed by orthopedics, whereas our aspect, which is the necrosis that need amputation, managed by general surgeon. Therefore, it is not the prognosis, it doesn't tell you it is a key emergency. It is one of the surgical emergencies that need to be sorted as emergency. But the prognosis of it, can even lead into losing of your foot. Therefore, prognosis is not okay from its point of view. But if it is managed appropriately with anti-inflammatory and offloading and proper the food where you can save the feed from food from that point of view. Yeah.
Okay, thank you very much. I don't see further questions, just comments to say thank you very much for a nice presentation. There are two comments about the podiatry and also wound care. I think we covered the wound care nurses that they're part of the team, but also we've spoken a lot about the podiatrists, and I think there's a request here that we should in the next sometime next year request a podiatrist to do presentations. So to encourage a colleague who posted this to refer us to those who are prepared to give talks, would gladly engage them and give them a platform to give a talk on management of diabetic foot or other conditions in terms of their field as podiatrists. And thank you very much, Dr. Malith, for this wonderful presentation. And thank you once more for accepting the invitation from Clinics Health Group to come and do the presentation. We've learned quite a lot, and I think there's a lot that we've learned about diabetic foot and also what the surgeons do. We know that there's also a role of the vascular surgeons in management of diabetic foot. There's a stage where you've got to involve them. But starting from managing glycemic, having a good glycemic control, food care, and also multidisciplinary team approach when patients come in, and making the timely intervention and up to the point where you prevent loss of limb. And we just want to thank you very much for giving us your thoughts on this one important topic. And also want to thank colleagues who joined us. We've been coming here every week to listen to us. We always have a regular participants joining us. And thanks to the team for marketing, we're working closely with us to make sure that we've got this presentation. Zuki this evening was on the background. And next week, we'll be having our last webinar. So it will be more like a symposium, we call it. It will be two speakers. We'll be concentrating on HIV/AIDS. And so we just want to say that be on the lookout for the invitation, and do please spread the message and invite as many as possible. We know that we just want to thank and acknowledge that you were able to come and join us despite the World Cup, Soccer World Cup that is taking place. We know that the games that are taking place even as we speak, but you chose to be with us this evening. So thank you very much, and may you be blessed and have a good evening till we meet again next week. Thanks. Bye.
Thank you.
Thank you.
Thank you.